Hey there all, let's continue our conversation on vestibular and cerebellar conditions. Okay, so we have been talking about vestibular migraine. So specifically vestibular elements of migraine, so in other words, somebody with migraine and their presentation includes dizziness and vertigo elements. It tends to skew a little bit older than a headache-only type presentation. In other words, it tends to manifest a little closer to middle age. It skews heavily female. And it's noted as commonly starting up when it's around midlife for women. So at this point, I would point out that there is a lot around and something that affects women more than men, especially as they start to get older, and that sometimes medicine doesn't take them seriously. And so you'll get these patients with serious elements of suffering and struggle and who have cycled between providers, and it can feel like you're the first one to take them seriously. And it's possible that you are. So if you're working in the vestibular field, you can undo a lot of harm that the system has created by its sexism, truly. So if you're looking for what do they call it? Doing the work, capital T, capital W, doing vestibular, honestly, gives a lot of opportunity to do that. You can make people's lives better simply by, doing your job when they tell you something is wrong. It sounds simple, and yet that's not what always happens. So vestibular migraine is definitely an area, partially because of its epidemiology, in which you will see social determinants of health. How does this actually get managed? There's no big standard, but there is some elements. So I've got two links here. This bottom one here on the left, this is a really cool article if you're interested. It's a little newer, 2021, Diagnosis and Management of Migraine in 10 Steps. Yeah, it's got very clear language, and it's a good one. And from it, as well as a little bit of some help from NIH, we know that some folks need one thing, some folks need another, okay? So there's prevention logic, and that's a class of medication. There's try this medication first logic, and that can be a second line. And then there's try this medication next, okay? So all this is to say that there's a lot of trial, as well as what are we trying to do? Are we trying to prevent, or do we already have the migraine, we're actively suffering, and we need something to make it stop? Those are two different rationales, and a lot of times patients will have medications for those two different focuses or functions. You can trial this. It's based on what you feel comfortable doing with your patient. 1 round of caffeine can improve symptoms in not quite 1 out of 5 patients, 1 out of 10, 1 out of 5. That's actually not bad for something that costs very little money, or maybe none if you just get a cup of coffee at your office. So it's worth a trial to see if that improves, because caffeine is a vasoconstrictor, and so if they possibly have the etiology related to vasodilation, then this would, in theory, improve the symptom presentation. But it's up to you and the patient. So this class of medications right here, the CGRP monoclonal antibodies, this is some of the newest stuff. It's only a couple years old, and it's pretty cool. When it works, gosh, it works. It can be really, really helpful. Here's the kicker: because it's newer, it's wildly expensive. I remember when these first came onto the market, and I had patients that were desperate, and they told me that their pills were considered experimental by their insurance, and so they couldn't get it. They're having to pay out of pocket, and it was $100 a pill. $100. And then about a year later, it became no longer experimental. It was confirmed. It's working. Here we go. And all of a sudden, it dropped to $10 for a 3-month supply. It was unreal. And so they would hoard their meds, and they'd cut them into quarters, which is hard to do with a tiny pill. It was awful, but the meds worked so well. And the really nice thing about the CGRP monoclonal antibodies is that not only do they work, but they tend to not have as many trade-offs. In other words, they're more specific for managing or eliminating the problem and not giving you as many side effects. So the major issue with a lot of medications for prevention and to clear out a migraine, they make you super sleepy, like you're toast for 24 hours. So that's not to say that CGRP doesn't necessarily do that. It's just less likely, right? We'll talk about this more during the summer, but it's pretty cool that there's something this is some of the first stuff that is specific for migraines. Everything else is a class of meds that's been used in other areas and found to kind of work in migraine, so they trial it. Okay, so prognosis, and here's some clinical pearls. So prognosis is variable. There's not a whole lot with definite guidance, but I would say this. If you can get them on the right med, it goes really well. And it turns out a lot of the right meds are actually in the antidepressant class, and one of the most consistent good ones is venlafaxine. So all this is if the patient wishes to advocate for themselves, great. It's not as though I go around saying, hey, prescribe this. That's not in my scope, and I'm not interested in those conversations, right? It's pretty rare that I request a med, and when I do, I'll tell you about that this summer. But overall, like if the patient has been trialing stuff and this hasn't been trialed yet, it's just a thought. They can ask, do you think this is appropriate? Yes or no. Some of the biggest things are caffeine and alcohol cessation. Yes, that helps massively. I can't tell you how many patients have like a pot and a half of coffee every day and come to me with vestibular migraine. I'm like, well, what if you cut your caffeine intake by 20% slowly over the next 6 weeks and let's see what happens. And sure enough, a lot of that helps. A lot of times migraines have a mental health component with them. In other words, the stress is very, very high, and that's aggravating a lot of the stuff, the machinery that tends to make a migraine happen. And so people, instead of taking an antidepressant, drink. So rather than do that, what if we consider an antidepressant? You're already putting something in your system, and hey, antidepressants sometimes help you fall asleep. So that might be 2 birds with 1 stone if you're lucky. So that's a thought. Otherwise, in terms of how they look, they're a mixed central peripheral in terms of how they look. They are a central diagnosis by etiology, but how they look will vary a lot. A lot of times you might need to like hold someone's hand, give them a little hug, be mental support, that sort of thing as you build a therapeutic alliance. Again, you might be talking to someone who's been through the ringer in terms of different providers, and it's not going so great. So prognosis here is variable, but it can be good. You can achieve management. If you get kind of like, okay, we're not getting as many episodes, I recognize my signs and symptoms so I can manage and I don't go as deeply or as often into the full tilt, high pain migraine, that's great, right? Maybe we stay a little more prodromal. Okay, let me take my med that stops it, in the sequence of things happening. Great. You can actually do some really well as they start to recognize triggers. So management is possible. Okay, let's go into the blood supply of the brain. So the vertebrobasilar vasculature, right? So in a way, I kind of don't care which one it is because all of it is in the same vicinity and it all takes care of similar structures. It's all just that brain stem, cerebellar, whatnot, yeah? So with this, anytime anything back here gets plaqued up, it creates an insufficiency. And when that happens, you can get these isolated attacks of vertigo that are some of the only initial symptoms. And it's kind of bizarre, but they kind of look like drop attacks, actually. And so if you've heard me in class, this is the person who goes to the hairstylist and they lean back and they rotate their head to the side so the stylist can wash their scalp or whatever. And suddenly they air quotes, fall asleep, but it's really blacking out. Yeah, sometimes that's the initial sign, or they're styling their hair, or they're kind of flipping their head in the shower type thing. So if you flip your head, look down at your feet and blow dry the back of your head, that sort of thing, that's a common one. Tying shoes, putting away cups up on a high shelf, anything that gets you up into that up and tilt or down and tilt. Sometimes those tend to do it. And that's when people first recognize it. So vertebrobasilar insufficiency is abbreviated as VBI. How does it present? Again, drop attacks. So this is a change in level of consciousness. It's not falling asleep, but people will say it like layman's terms. They will come to you. Yeah, I keep falling asleep out of the blue. It's a drop attack, okay? It's a loss of consciousness due to impaired blood supply. Because it's also hitting up on the brainstem, it's hitting the tracts, and so you're getting a little bit of hemiparesis sometimes. Pupils tend to be different sizes. And then all this cranial nerve whatnot, okay, cranial nerve and different, this hits the occipital lobe, and you might get some of that weird, lateral medullary syndrome and stuff like that. All of this brainstem whatnot can kick in, okay? As well as kind of this occipital lobe stuff. But the only 3 I want you to know from me are these ones, because these are kind of the really super iconic ones. And the drop attack, the pupil size, and the weakness to one limb, yeah, that's a classic VBI presentation. What do? They're going to scan. They're going to look at everything and see how the blood is flowing. So MRA, this is an X-ray with standard angiography. So the X-ray and the MRI with the dye. And they're looking at what's going on to see what they need to do. They might also do some CTs and all kinds of things, making sure that there wasn't an event of hypoxia or possibly already a stroke. What do? Well, first thing you can do is all of your TIA stroke prevention type stuff. Otherwise, they can go in and do a bypass graft, or they can go in and try to scrape out all of the plaque. There's all kinds of things they can do. They can lay a stent. There's a lot of options. So very similar to the heart, in which they try to push stuff out of the way, scrape it out, go around it. Same thing, just a different vessel. Prognosis is variable. If they've had a stroke from the vertebral artery, recurrence rate is really high. So you really want to try and nip this in the bud as quickly as you can. Otherwise, prognosis varies based on how bad the plaque buildup is, the patient's age, and if they have any other conditions at the same time. Okay, so there's stroke, and there's also just stroke. So coming up a little bit higher, I have this here just to kind of distinguish it. So with a pure VBI, vertebrobasilar insufficiency, there isn't any hearing issue, but with other types such as AICA, PICA, there is more of that issue, okay? So just kind of giving you a little bit of sense here. And then because AICA and PICA hit more of that cerebellar type vasculature area, you're going to have more of those cerebellar signs and symptoms with dysdiadochokinesia, dysmetria, coordination impairments, vertigo, all that sort of thing. And honestly, the thing here is to know that they need vestibular rehab and neuro rehab, but careful with prognosis. It's probably not going to be a 100% recovery if a stroke here happens. So again, earlier we were talking about insufficiency, right? There's just reduced blood flow in a stroke. There's straight up not blood flow. So if we actually get all the way to that point, limited prognosis, okay? We come to the big one. So a stroke in the cerebellum. I once heard a physical medicine doc call it the king of vertigo. I agree. This is a bad one. So the reason it's the king of vertigo is because the cerebellum is what manages a lot of your postural control and the ability of your eyes to coordinate with other structures. And without that, you're just disoriented on a deep neurologic level. So this is a rough one. And then anatomically, any issue that happens back here also tends to obstruct the fourth ventricle. And so you can end up with this increased intracranial pressure that causes herniation of the bottom of the cerebellum down through the foramen magnum. So we call this herniation of the cerebellar tonsils. And when that happens, you are in big trouble. Now we might be talking neurosurgery, okay? So how do they look? Again, dizziness or vertigo in the vast majority of cases, ataxia, nausea and vomiting because they're disoriented, sometimes some cranial nerve deficits, and it's usually double vision and nystagmus. The nystagmus has a lot of traits. The one I want you to know is pure vertical, okay, pure vertical. And then if there are motor deficits, they're same-sided. So if you have left side cerebellar issues, left side weakness / impairment of those limbs, okay? And the weakness is mild. Like if you're typically a 5 out of 5, for your muscle strength, it would be like a 4. So it's mild. It's there, but it's not profound. Prognosis, moderate to poor, actually. It is the least likely of all vestibular diagnoses to recover across the board, peripheral and central. Partially because the seat of error correction is damaged, yeah. Otherwise, the mortality rate is pretty high just because you're located near the brainstem. Yeah, so that's part of it. TBI, TBI. Okay, so there's a lot more to say about this, but I'm abbreviating it on purpose because you're going to get a lot more about TBI in other discussions, and then we've also just talked about TBI specifically. But what can happen here is from the initial force of the injury, you can end up with secondary BPPV, knocking otoconia loose, just due to physics. Otherwise, the presentation is very similar to migraine-associated dizziness. And then they also tend to get vertigo or at least a headache with higher exertion. So this is part of that energy crisis that occurs after the initial injury, no matter the severity, whether it's mild, like a concussion, or severe, like all the way out into the Rancho ones. Okay, so what do we do? Lots of medication and rehab. With the less severe the injury, the better the prognosis. The more severe the injury, the more variable. But even in severe TBI, there's always hope. I have actually seen people recover and go to grad school type thing after severe TBI. That is exceptional and rare, but there is a lot of hope no matter what. You hang in there. Ototoxicity. So this is actually a peripheral condition, but because of its presentation, by convention, it's usually taught during central diagnoses. This is damage to the inner hair cells that's either permanent or transient. The source is almost always medication or chemotherapy. And so this is a lot more common than we initially appreciated. And there's really good literature looking at, okay, what is the source of ototoxicity? And a lot of times it's medications. So the presentation, it depends on how fast the medication or whatever the damage causer is, the insult, kind of gets in there. And then that also, it's different if it's both sides or just one side. And then how severe the damage is. So magnitude, speed, and is it unilateral or bilateral? So if the onset is really fast, it makes it harder for the patient to compensate. You can have a lot of issues with headache, a sense of fullness in your ears, like they need to pop, imbalance with difficulty in ambulating, blurred vision, vomiting, and nystagmus, motion sensitivity and impaired tolerance of head movement, a wide base gait, and particularly walking in the dark is tough. That's across the board in vestibular, but it's more notable in ototoxicity. So one of the critters that always tends to cause it are called aminoglycoside antibiotics. And this is an antibiotic that's given all the time, so gentamicin and vancomycin. It's worth noting that vancomycin is the drug of choice for sepsis. So in other words, you're going to see this all the time in the hospital. You don't need to know these other drugs. They're just here for knowledge and exposure. We'll talk about this more during the summer. But I do want you to know that aminoglycoside antibiotics are among the most well-known and common for causing damage to the inner ear, resulting in vestibular impairment. So we've got more stuff here, but we'll talk about this more in the summer. I'm just kind of giving you a little heads up. There's a lot of stuff that can mess with your inner hair cells of the ear. And then one more thing, central diagnoses don't do as well as peripheral diagnoses, but even among the central diagnoses, far and above the worst is cerebellar. So what we have here is the Dizziness Handicap Index. This is a rating of how bad your dizziness is, with 100 being worse than 0, 0 being no issues with dizziness. And note the change. So it should start high, drop low, and note that there's the least amount of change in cerebellar. So they start here and they don't go down that much. Yeah, really sucks, right? Meanwhile, look at TBI, big drop. Yeah, that's a huge drop. Okay, then we come over to DGI. We don't use the DGI as much anymore. This is a measure of balance with mobility, mostly walking and similar activities. So it should higher being a better score, 24 being the highest you can get. So it should start low and go high. Note that it barely moves in cerebellar, right? Barely moves. Look at how much it jumps in stroke. Yeah. Oh, God. Yeah, especially with these mixed conditions. Yeah, that really jumps. PT makes a big difference. What this means is that cerebellar has the lowest potential for recovery of all the diagnoses, and among the central especially. So just kind of giving you a frame of reference for what to expect clinically. Okay, I think that's it, team.